Starting. All attendees are in listen-only mode.
Good afternoon or morning, depending on where you're viewing us from. This is the ASWA webinar on Legionella. We certainly appreciate everyone joining us today. Legionella is becoming a very important topic for states as more and more facilities explore treatment options to control Legionella and other pathogens in premise plumbing. This brings them potentially under the regulation of state drinking water programs. We're pleased to have Dr. Janet Stout of the Special Pathogens Laboratory generously sharing her time and expertise with us. She is an internationally recognized expert on the subject and has extensive experience not only with monitoring and analysis for Legionella, but also with preventative treatment and response to disease outbreaks. We really appreciate her taking her time to do this webinar for the states. I also want to extend a special thank you to Ken Bousfield and his staff in Utah for suggesting this webinar as a way to educate states about this important issue. If you know of speakers, topics, things that would be important for states to hear, let us know and we'll be glad to work with you, possibly set up another webinar for states on other issues. So we're about ready to get started. To simplify the logistics today, we're not going to do any live audio questions. We ask everybody to submit their questions through the question box that you'll find in the panel, control panel on your screen for the webinar. And we'll answer as many of those as we can before the time runs out. If we still have questions that are outstanding, we'll follow up with Dr. Stout later and get those into a question and answer document that will be posted along with the recording of the webinar. We'll provide you with information when the webinar recording and questions and answers and slide deck are posted on the website, where you can view those later or refer them to other people in your office who weren't able to join us today. So with that, I'm going to get right into it, and I'll turn it over to Dr. Stout for the content of the webinar.
Thank you very much, Daryl, and thanks everybody for attending. I want to thank the Association of State Drinking Water Administrators for hosting the webinar today, and I'm grateful for the opportunity to share with you kind of my life with Legionella, which I'm always shocked to say now spans more than 30 years of active research in Legionnaire's disease and operating a Legionella reference laboratory. As Daryl mentioned, this opportunity came about because some of the staff of the Utah Division of Drinking Water attended my lecture at the AWWA Conference on Water Quality back in November. So we have, as Daryl said, them to thank for bringing us together today. So I want to start by wishing you all a happy spring. We were talking offline about is it ever going to come? But it will, and so there's a bouquet of flowers there for you. So we got a lot of ground to cover today, and so bear with me as we go through the topics, just sort of give you a roadmap of where we're going. I want to talk about the disease, Legionnaire's disease, what's new, what may be new to you based on my experience. I want to talk about the paradigm shift in the sort of the history of where that came about, where drinking water, not cooling towers, are really considered the major source of transmission for Legionnaire's disease. We're going to talk about approaches to prevention and the fact that much of what we know today has its origins in the prevention of Legionnaire's disease in hospitals or the healthcare setting. We're also going to talk about the role of environmental surveillance in disease prevention and the methods that are used to do that. So I want to inform you about that. And also really, I think, an area of great interest, establishing targets for disease control and what I call stop chasing zero. And I'll talk a little bit more about that in some detail. And then finally, disinfection measures that are applied. So this is secondary water treatment at the building level, and what I've learned over the many, many years of investigating these various disinfection technologies. So what I want to do now is really talk about the disease just a little bit and what we know today about it. So beginning with, who gets Legionnaire's disease? So many of you are familiar with these susceptible hosts. So as we get older, we're more susceptible to any number of things, including Legionnaire's disease. Smoking is the single most common risk factor associated with an individual's increased risk of getting Legionnaire's disease if exposed to Legionella. This is something that you might not be aware of. Studies by our own group and others have shown that almost 25% of the reported cases have none of those typical risk factors. They're not elderly, they're not smokers, they're kind of like you and me. So as the diagnostic techniques have been more broadly applied, we're finding Legionnaire's disease outside those typical risk groups. And then finally, the immunocompromised, or probably what you would term sensitive subpopulations. These are the individuals that are at greatest risk of getting Legionnaire's disease if they're exposed to Legionella bacteria, particularly Legionella pneumophilus serogroup 1. So classically, immunocompromised patients, transplant patients, individuals that are on high-dose corticosteroids for chronic lung disease like COPD, diabetics, and those that are receiving chemotherapy for cancer are at the greatest risk of acquiring Legionnaire's disease. I wanted to say just a couple words about the mode of transmission of Legionnaire's disease. So 3 things have to happen for someone to get Legionnaire's disease, and it's actually fairly rare for each of these things to happen in the right sequence in the right time. So the first is exposure to water that contains pathogenic Legionella, and we're going to talk a little bit later about what that means, but it means that Legionella species and strains that are capable of causing disease. So you have to have that organism in the water. It has to get from that water into the individual's lungs. So water containing Legionella has to reach down into the airway of the host. And then finally, how does it get from that water into the airway? This is the mode of transmission. So everybody knows that Legionnaire's disease or Legionella bacteria are transmitted via aerosolization, or that it's trapped in the mist, we breathe the mist, and then we go on to develop the disease if we're susceptible. But many of you are probably not as familiar with the concept of aspiration as a mode of transmission for Legionnaire's disease. And so what this means is that water that contains the bacteria Legionella is in contact with the upper airway, and then secretions in the upper airway are aspirated down into the lung. So many of you are familiar with overt aspiration, which is that choking where something, quote unquote, goes down the wrong pipe. So that's overt aspiration. But there's also something called microaspiration, which most of us do when we're sleeping. There's no overt choking episode, but secretions still make it down into the lung. So this is also a common mode of transmission, particularly for hospitalized individuals. So in summary on Legionnaire's disease, it's relatively rare. About 2 to 5% of community-acquired pneumonias are Legionnaire's disease. Most of, but not all, the cases are occurring in individuals with health conditions that increase their risk. And then finally, it's a very treatable infection if, and this is a big if the diagnosis is made early. And the antibiotics of choice are macrolides like azithromycin or clarithromycin, or some of you might have had a Z-Pak for a sinus infection. That's azithromycin, very effective antibiotic, and also quinolones like ciprofloxacin or levofloxacin. What's important to know is that antibiotics in the class of penicillins or penicillin-like antibiotics are completely ineffective in the treatment of Legionnaire's disease. So sometimes that's the first choice of a physician when they see a patient with pneumonia and they don't think about Legionella, so they'll give them a penicillin or a penicillin derivative, and unfortunately that patient goes on to worsen and often ends up in the intensive care unit. So it's very treatable if diagnosis is made early. My favorite myth about Legionella, and that I hear this most often, is that Legionella is everywhere, and so what's the point of even looking for it? So what is it, is that really true? What do the studies show that have actually asked that question? Is Legionella there? So if you look at the literature, depending on the study, between 20 and 70% of buildings can be colonized with Legionella. So the rule of thumb I always say is about half of the buildings that we look for Legionella in will find it. Well, it's very important, I would think, to know which half you're in. Are you in the half that has Legionella in the building, or are you in the half that doesn't? So Legionella is not everywhere. And then in these studies, certain factors of the building have been associated with the presence of Legionella. But I want to point out that there are no predictive factors that will tell you for sure Legionella is present or absent. The only way to know that is to test for Legionella. So lower hot water temperatures below 50 centigrade or 122 Fahrenheit, complex buildings with complex hot water systems, so that's the buildings taller than 10 stories, and then interruption of water service, like brown water events where the pressure within the building dislodges the sediment material or biofilm within the building, have been associated with colonization and transmission. So I want to say a little bit about prevention of Legionnaire's disease. How are we doing? And this is where you come in, because I want to tell you that we need your help because Legionella is winning. The disease is increasing, and this poses new challenges with regard to control, which is why we're talking together today. Well, what I mean by Legionnaire's disease is increasing. Well, I've seen many of these alerts, public health alerts from health departments across the United States. This one's from Pennsylvania, and you'll see the subject is increased Legionella infections in Pennsylvania. So I've seen these public health alerts in New York, Maryland, Pennsylvania, Wisconsin, Illinois, all across the United States, because these alerts are issued when there's an uptick in cases. So that's one clue. Other clues you'll find in the published literature. This is a report from 2008 from Emory University investigators, and the title is Increasing Incidence of Legionellosis in the United States, Changing Epidemiologic Trends. Well, the conclusions that I highlight at the bottom here are this. Cases have increased substantially, particularly in the eastern United States and among middle-aged adults. So again, that group of individuals that don't have those typical risk factors are getting Legionnaire's disease, and there was a notation in this publication in the eastern United States. So the real take-home message is public health professionals should focus on prevention of this important and increasing public health problem. Well, that was 2008. Well, in 2011, the Centers for Disease Control and Prevention published this report in Morbidity Mortality Weekly Report, MMWR, that had this startling headline of increased cases over the last 10 years, more than 200%. So big increase in reported cases noted by the CDC. Well, you might be kind of scratching your head and going, well, what's going on? Why the increase? Why this dramatic increase? Well, there's multiple factors that have been discussed. One is better reporting. Now, this disease is mandatory to be reported in almost all states in the United States because of its public health significance. So there's certainly better reporting, but probably increase in diagnostic testing. The urinary antigen test, which detects Legionella pneumophilus serogroup 1 only, but that is the one most commonly associated with disease, is being applied more broadly. And so over the last 10 years or so, anybody with pneumonia and a smart physician is getting that urine test for Legionella. And so that means more cases are being diagnosed. And then finally, which is really interesting, there's a hypothesis that environmental factors are actually contributing to the increase in cases. And what does that mean? Well, this headline, rain, flooding likely led to spike in Legionnaire's disease. So wet weather events have been associated or hypothesized as being associated with outbreaks of Legionnaire's disease. And actually also the reverse, drought conditions. Well, what do those two things have in common? Well, they affect source water quality, and you all, by more than anybody, would know that. So when it's wet weather, there's all that turbulence, and that stirs up the sediment and organic material. And in drought conditions, the water is being pulled from close to those soil deposits, and so you get the same kind of effect. So certainly I think there's enough evidence now accumulating that weather events are contributing. Well, many people will tell me, well, there really isn't that much Legionnaire's disease, so, why are we worried about it? Well, I like to put some numbers to it. So in the United States, each year, there's about 600,000 cases of pneumonia that are severe enough to require hospitalization. And among those, when studies have been done looking at every single one of those cases that come in and doing Legionella diagnostic tests, these studies show about 2 to 5% of those cases are caused by Legionella, and most typically Legionella pneumophilus serogroup 1. So that translates into about 30,000 cases per year that we know about. And the reason I say that we know about is because it's a undiagnosed or the diagnosis is missed in many people. So this is a minimum number, so it's actually probably quite a bit higher. And then I wanted to sort of shine the spotlight on hospitals again. So it's a particular problem in hospitals because there's a lot of the cases that are occurring because they're exposed to the water in the hospital that has Legionella in it. So these statistics from CDC, 35% of the reported cases were from hospitals, and that ranged between 25 and 45%. But most importantly, the risk of dying of Legionnaire's disease dramatically increases if you get Legionnaire's disease in a hospital, almost 30% case fatality rate. And that's in comparison to about 10% in the community. So big problem in hospitals. It's also costly. So these are reasons why prevention is worth our effort. So Sarah Collier from the CDC put some numbers together, estimating a cost per patient about $34,000, and I emphasize there that that's a minimum because it doesn't take very long to spend $34,000 if the patient's in the ICU, which is where most of these Legionella patients are. And their stay is longer, average stay of 10 days, much longer than other forms of pneumonia, and all of that translates to about 100 to 300 million healthcare dollars spent each year on Legionnaire's disease. So it's an expensive proposition. So what you see now on the slide is a culture plate of Legionella colonies growing. So I want to sort of turn over from the clinical side to the environmental and talk about the fact that a drop of water can contain thousands of Legionella bacteria. Well, I want to emphasize that Legionella is not by itself, of course. As a microbiologist, Legionella is a naturally occurring bacteria, not a contaminant of water, and it's part of a community of microorganisms. And I always like to share my favorite microbiology words, and this is one of them, consortium. Isn't that a cool word? So that's just the community of microorganisms among which Legionella hangs out. Well, it hangs out with certain organisms because it's beneficial to Legionella, or they live synergistically, one benefiting the other. And in water systems, these other microbes that help Legionella to grow are typically protozoa like amoeba, which you see here on the left part of the slide. You see the cyst form and the trophozoite form. And other bacteria in water can help Legionella to grow. So those little dots are called satellite colonies, and the glob there on the top is the growth of the other bacteria. Legionella would not grow in that media unless that organism was secreting nutrients that help Legionella to grow, like cysteine. So both protozoa and other bacteria help Legionella to grow. Well, how does Legionella get into our water in the first place? And some of this you may know and some of it you may not. But I like to tell people that, you know, Legionella is really coming in the source water into the buildings, but it's in basically undetectable or very, very, very low concentration. So in my experience, when we sample the cold water coming into the building after the meter, we don't find much Legionella. But when that bacteria in low or undetectable numbers gets over into the warm water distribution systems, the cooling towers, that's where it grows to high numbers or is amplified. And certainly biofilm within these systems can contribute to that. So it's actually surviving both in the biofilm phase and in the bulk water or planktonic phase. But it's those warm water and nutrients that allow it to multiply to high numbers. Well, I want to tell you a little bit about the history of Legionella in building/hospital water systems, because actually our group is part of that history. And as evidence of it, you can see this picture of a young Janet Stout standing next to the physician Victor Yu. who at the Pittsburgh VA back in the 1980s saw a patient with pneumonia that didn't look any different than any other patient with pneumonia, but this patient had Legionnaire's disease. And so he systematically went about looking for Legionnaire's disease in every hospitalized patient with pneumonia and found over 100 cases over 5 years. So redefined the fact that Legionella was occurring not as an epidemic, but constantly occurring within this building because Legionella was in the building water system, the hot water system of the hospital. And that's the role that I played. And it was so dramatic a finding back in the 1980s that it was published in the New England Journal of Medicine in 1982, the title being Ubiquitousness of Legionella pneumophila in the Water Supply of a Hospital with Endemic Legionnaire's Disease. Well, prior to this publication and this work, everybody focused on cooling towers as the source of Legionnaire's disease dating back to the 1976 outbreak at the Bellevue Stratford Hotel. So this was a paradigm shift, a shift away from focusing on cooling towers as the source of Legionnaire's disease to water distribution systems. So cooling towers are not a common source for sporadic cases or hospital-acquired cases, can be and are associated with large outbreaks. So cooling towers aren't off the hook, but the emphasis is on water distribution systems. So what we know now is that the potable water, particularly the warm water, in hospitals and other buildings is the most important source of Legionella transmission. So that's one of the important takeaways. Well, historically, your sort of area of municipal water treatment, public water systems, has not been a focus for outbreaks or disinfection efforts. So historically not a focus. And the reason for that is the regulatory approach from the Environmental Protection Agency. So it's an opportunistic pathogen, so there's no level specified or regulated for as a public health concern. And the EPA uses treatment technique criteria for establishing acceptable water for Legionella concerns. So they say considers water acceptable if the treatment plant uses techniques to control parasites like Giardia and Cryptosporidium. Well, we know that those techniques don't eliminate or control Legionella, but that's the status of the regulation. Well, I ran across a recent publication that addresses this issue. Community water systems may be a significant source for Legionella. So I'm kind of looking at, well, maybe you're not off the hook entirely. So this publication in Epidemiology and Infection will come out in print next month. So it's available online now. Community Outbreak of Legionellosis and Environmental Investigation into a Community Water System. So I really thought this would be interesting to share with you. So this was in New Jersey. The Department of Health investigates a number of cases of Legionnaire's disease, senior high-rise, geriatric center, single-family houses. And what they found was that the investigation pointed the finger at poorly maintained large volume water storage tank and the surrounding distribution. And specifically what they found were low flow conditions in the network, low or no levels of chlorine in the distribution network or in this large volume water storage tank. And this large volume tank was like 1 million gallons, and so the water didn't mix within that tank. And then finally they had no regular flushing program of water mains. And so the recommendations from this publication is that maybe when there's outbreaks we should include community water systems as a possible source for Legionella, and that community water systems that are supplied by surface water, particularly in the summer where temperatures and nutrients go up, they can amplify Legionella. And in this report they did find Legionella in the distribution network. So their final recommendation here is a proactive one. Public health action in the absence of disease is recommended. So don't wait. Look at these systems with regard to those factors that they found were associated and take action now. Well, this is a nice segue into the public health approach to prevention of Legionnaire's disease and focusing on the word proactive. So historically the approach to disease prevention has been reactive, and this is the CDC approach, basically waiting until cases of Legionnaire's disease are detected, then do an investigation. If you find the source, like the water distribution system, then decontaminate. Well, back in the early 90s, as a result of our experience at the Pittsburgh VA, we said it's better to be proactive. Do environmental surveillance before people get sick, and then also perform clinical surveillance in a hospital looking for the disease. And if you find a high level of positivity of Legionella, if you find disease, then consider disinfection. Well, this approach was integrated into the first guideline for hospitals from the Allegheny County Health Department in western Pennsylvania, this proactive approach. And in 2005, in the American Journal of Infection Control, we published this paper, A Proactive Approach to Prevention of Healthcare-Acquired Legionnaire's Disease, the Allegheny County Pittsburgh Experience. And so we asked a simple question. Before the guideline was in place, how much Legionnaire's disease was there in hospitals? And did that change after the proactive approach was implemented and recommended? So just to walk you through it, what is this approach? So you start with testing the water system. Did you find Legionella, particularly Legionella pneumophilus serogroup 1? The answer is yes. Were there any cases associated with this facility? If the answer is yes to both those questions, you want to consider disinfection now. If the answer is no to prior cases, is the water distribution extensively colonized with Legionella? Meaning if you take 10 water samples from 10 sites within the hospital, are more than 3 of those sites more than 30% positive? If the answer is yes, then you're likely to see cases of Legionnaire's disease. If the answer is no, you don't give up. You keep looking for cases until you find them. So that's the approach. So we wanted to know, did cases of hospital-acquired Legionnaire's disease go down after that approach? So what we did was in 48 hospitals in western Pennsylvania, we asked how many performed environmental surveillance. 65% did. And then we looked at how many cases there were before and after the guidelines. So there was a significant, statistically significant reduction in reported cases of hospital-acquired Legionnaire's disease after the guideline was out, 33% versus 9%. And the reason for that, I believe, is that most of them disinfected their water system, their hot water system. So secondary disinfection worked in hospitals to prevent the disease. So that's a new segue over to disinfection options. Well, what were they doing in those hospitals to reduce the presence of Legionella in their water distribution systems? If you want to, all of these methods are reviewed in a review paper that we published in Infection Control and Hospital Epidemiology. So if any of these publications that I cite during the talk today, if you'd like a copy for educational purposes, just get in touch with me and I'll be happy to provide them. So a resource for a review paper on disinfection technology. Well, what are these methods? So there's shock methods, heat and flush and shock chlorination on the left, and then continuous methods where you continually add another disinfectant, chlorination, copper silver ionization, chlorine dioxide, monochloramine, and point-of-use filtration. So these are the tools in the toolbox. Well, some of them you're very familiar with because of the EPA Safe Drinking Water Act says you're allowed to use certain chemicals in our drinking water to control organisms of public health significance. So on the left side of the slide, there's the list for municipal water treatment covered by the Safe Drinking Water Act, chlorine, chlorine dioxide, monochloramine. Well, those also appear on the right side under building water treatment or secondary water treatment, but they're joined by a couple that are not covered under the Safe Drinking Water Act, copper silver ionization and point-of-use filters. And those are not covered under Safe Drinking Water Act because they were never intended to be applied for municipal water treatment. They're only used in building water treatment. So I wanted to make that clear to everybody. Well, just a few words on shock heat disinfection or thermal heat and flush, which we developed at the Pittsburgh VA back in the 80s. It has to be a 30-minute flush at each outlet at 160 to 170 degrees. Not easy to achieve. The publication that's listed there is a publication that shows that if you do it at a lower temperature or not long enough, you're going to fail. And then the effects are short-lived. Now, many people believe that once you do these disinfection measures, Legionella is killed throughout the entire system and it's never going to come back. So I want to show you this graph, Legionella rebound after shock disinfection. So this is in one building, So along the one axis is distal site positivity and time by date. So we started out over 60% of the outlets are positive. They did a thermal shock that reduced it to 20%. It's only 2 weeks later that you see that bar spike back up over to 80% positivity. So then they went, okay, so heat and flush didn't work so well, let's do chlorine dioxide shock treatment. So they did 2 of them, and then about a month later, you see the bar go way back up again. So I want you to be clear that when you do these shock treatments, Legionella will come back. So here's my image that I want you to sort of stick in your head as whack-a-mole. I don't know if you ever have a Dave and Buster's or a Chuck E. Cheese's near you, but that's a game that you play. So you knock it down, but it pops back up. So that's the image I want you to remember when you're talking about shock disinfection. Well, let's talk about chlorine. Less expensive, less effective? Maybe. Chlorine seems to be sort of the darling of a lot of people in terms of water treatment. So what's the story on chlorination? Well, when you do a shock chlorination, you take it up very, very high, 20 to 50 parts per million. You flush the outlets, making sure that there's at least 2 milligrams per liter. Then you hold that for at least 2 hours. Many people do it overnight. Well, there are a lot of downsides. Besides the high levels of chlorine and the disinfection byproducts associated with that, corrosion, and then again, recolonization will occur after hyperchlorination. And this is just a visual depiction of some scale and corrosion in a pipe. So just to sort of hammer home what happens when you have high level chlorine in copper piping. I want to share with you some new research on chlorine efficiency, some things that you might not be quite aware of. So this is a Journal of Hospital Infection in 2010, Resistance of Legionella Serogroup 1 biofilms to chlorine-based disinfection. Up to 50 parts per million Legionella survived within the biofilm. So that's part the biofilm inactivating the chlorine and part protection of the organism either itself or in amoeba cysts. So Legionella can survive very high amounts of chlorine. New research, this is an article in Water Research in 2012, Legionella pneumophila transcriptional response to chlorine treatment. Basically, this article just says that there's a genetic basis for chlorine resistance within Legionella. And it's not just this report. This is one reported in MBio, Legionella resistance to chlorine. So I highlighted the points on the slide, and basically it says that this genetic element confers increased resistance not only to bleach, hydrogen peroxide, and some antibiotics. So again, there's this genetic element that confers a higher level of resistance to chlorine on Legionella. So Legionella pneumophila carries these genetic elements, enhanced resistance to bleach, and some antibiotics. So just to summarize the history on chlorination, Legionella is more tolerant to chlorine for various reasons. Rebound or recolonization occurs after chlorination. And then, of course, the hospitals that used continuous chlorination back in the 80s had such extensive corrosion that they had to replace all of their copper piping for millions of dollars and eventually switched and abandoned chlorination for other technologies. One of those technologies is chlorine dioxide. So what have we learned about chlorine dioxide? Our first study was published in the American Water Works Journal in 2004. This was a hospital study in eastern Pennsylvania, and what they did was they put chlorine dioxide on the reservoir of the hospital. And what this slide shows is when you apply chlorine dioxide to the cold water of a building or buildings, it takes a long time for Legionella positivity to be reduced. So this slide shows percent positivity over 30% at the early phase, and then almost a year later before it got down to below 10%. So why does it take so long? I was sort of scratching my head. So the kinetics of chlorine dioxide in hot water explains the reason. So you put chlorine dioxide in at 0.5 to 0.8, 0.8 being the maximum allowable amount. But when it goes over to the cold water side of the building, you maintain that level nicely. But when it goes over to the hot water system, it essentially disappears and breaks down into its byproducts chlorite and chlorate. So that explains why where Legionella is living in the warm water part of the building, if you put chlorine dioxide on the cold water alone, it's going to take a long time. It's essentially your CT value, concentration times time. So that explained why it took so long. We also learned that the presence of corrosion scale negatively impacts the efficacy of chlorine dioxide. And this was published in 2008 in water research by one of our graduate students at the University of Pittsburgh. So another thing to be aware of, if there's galvanized pipe, chlorine dioxide may have a problem. So again, cold water application, extended period of time necessary to have the desired effect. You may want to add chlorine dioxide directly to the hot water to get a more rapid response. So it gases off at high temperature, reacts very quickly, particularly in the presence of high organic and scale and disinfection. It does have some advantages. It's effective against Legionella and other waterborne pathogens. You can put it on the cold water, which is an advantage and a disadvantage because it does take a lot longer to have an effect. And you do need to monitor the disinfection byproducts, chlorite. Well, what about monochloramine? What's the story about monochloramine as a new approach for Legionella control in hospitals and building water systems? So I want to share with you some information and perspective about this. So going way back to 2003, CDC investigators first reported that hospitals and municipalities that were treating with monochloramine had less Legionella in their water and less Legionnaire's disease. Well, that was interesting because that wasn't true for municipalities using chlorine. Well, then a report from Italy in 2012, American Journal of Infection Control, where they used a monochloramine generation system on the hospital and had very, very good results by on-site generation. And their conclusion was monochloramine could represent a good alternative to chlorine dioxide in controlling Legionella in buildings. Well, I learned about this in 2009 when I went to the International Legionella Symposium. It was in Paris. Somebody had to go. And I said to myself, we need to try this system in the United States. So we used this system, which is called Sanakill from Sanapure. It's the only company at the time that was making an on-site generation system, and this company was based in Italy. And I said, you know, maybe if I can find a hospital, we can put it in the United States, you'll donate the system for evaluation. Well, they did. And we had a simple objective. Does it work? You know, we put it on the hot water system of the hospital. What happens? And so this is what I want to show you. So again, percent positivity of distal outlets over time. So we start out with over 50% of the outlets being positive for Legionella pneumophilus serogroup 1. And then at 1 week, we say, well, what's happening now? And this is about 30 distal sites are tested. 1 week, dropped from over 50, it was actually higher than that to start, down to 10%. 1 month, 2 months, 3 months, 4 months, 5 months, 6 months. Now, two things about this graph. One is dramatic reduction. The second is it's not zero. It's almost zero, but not quite zero. So what did we learn? You're injecting at about 1.5 to 3 parts per million. The benefits, it's less disinfection byproducts than chlorine. You have on-site generation, and you can apply it to hot water where the organism lives. And so now we've proven it's effective in reducing Legionella positivity. With any disinfection technology, you have to monitor for Legionella and the disinfectant. So that's Legionella monochloramine. And we found that although most of the time the ammonia levels were low, when there was a problem, we saw it go up. So we recommend monitoring total ammonia. And then pay attention to reagent levels because one of the precursors is a chlorine-based compound, which if it's stored at high temperatures like during the summer in the tank room can degrade. So you want to pay attention to that. And we published this in November in Infection Control and Hospital Epidemiology, so another piece of bedtime reading for you. Copper-silver ionization. So copper and silver ions are released. So at the bottom of the picture are what are called flow cells, and inside the flow cell are bars made up of copper and silver. And at the upper part of the picture is a controller, basically a voltage regulator that sends electricity across the bars. And those levels of ions are below EPA drinking water levels. And again, that's cold water drinking. This is generated only in the hot water. So you put it on hot water. It's an EPA registered device. and there are no precursor chemicals. Lots of publications in the medical literature on efficacy of ionization going back to the 90s, so there's a lot of information that you can read about. I wanted to give you a real-life example. So this is one hospital that used two approaches. So in one building, they had high level of Legionella colonization, most outlets positive. They installed a monochloramine system. The other building, same thing, high level of positivity. They installed a copper-silver system. So like our study hospital, high level of positivity of outlets before monochloramine started drops it down to below 10%. And again, not completely eliminated, but significantly reduced. And before treatment, they had cases. After treatment, no cases. Same thing with copper-silver ionization. More than 50% of the outlets were positive before copper-silver was applied, and then it went down to less than 10% after application of copper-silver on the hot water. It takes a little bit longer for the effect with copper-silver, but and then a little bit longer is a few weeks as opposed to a week with monochloramine. Well, in the hospitals with high-risk populations like transplant patients and neonates, I make this statement. We filter the air, so there's HEPA filtration, but we let them drink tap water? Does that sound right? Probably not. So for high-risk patients, there's point-of-use filtration. So you've got bone marrow transplant, hematology, oncology. And our first publication on the efficacy of point-of-use filtration was published in 2005 in the American Journal of Infection Control. And at that time, the filters were only good for 14 days. Well, subsequently, they extended that to 30 days, and these are 0.2 micron filters. And there were some reports of problems like clogging due to particulates, and so there was a need for improvement. So now the companies say you can use them longer, this new filter. Well, we don't believe anybody. We have to try it ourselves. So this is what we did. So it says it's good for 62 days. So we went to a cancer treatment center, and we took 5 faucets that didn't have the filter and 5 faucets that did, and we tested them every week for Legionella and total bacteria, and we did this for more than 14 weeks. And we published this in the American Journal of Infection Control in November, and in that publication you'll see this graph. So the blue bars are Legionella counts, colony-forming units per milliliter, in the control faucets. The red zeros are the amount of Legionella from the water coming through the filters, and it went out to 91 days before we even got one of those 5 faucets with 1 colony-forming unit of Legionella. So we proved that they matched their labeling claim, and it actually went out further than 62 days. So the conclusions on point-of-use filters are sometimes system-wide disinfection is not always necessary or preferred. So you can actually put these filters on in an emergency. If there's an outbreak, you can call up the companies and say, put one in, and they'll be there within 48 hours. They do last longer than 60 days, and some hospitals are putting these on high-risk units long-term in addition to systematic secondary disinfection. And these high-risk patients go home, so I always like to mention this. If somebody's in a home situation and a high-risk patient, they can get these filters as well. They're called clean pack filters. This is one of my favorite cartoons. That's not quite the stool sample we had in mind, Mr. O'Donnell. So I want to talk just briefly about laboratory testing and sample collection and processing, just to tell you what's happening in the lab. So what's the best sample to collect, and how do you collect it? And one of the most common questions is, how much water do we need to do a test for Legionella? So I want to tell you about some findings. So some people say collect a liter. Now, do you really need a liter of water? And the answer is no. So you can see that the recovery of Legionella from lesser volumes is almost as effective. So you go from 100% to 98% as you go from 1,000 to 200 to 100. So we recommend our bottles are 250 ml, and we process 100 ml in the laboratory, and so this data shows that that's more than adequate. Now, a lot of people, when they're out in the field, they sort of approach Legionella collection like they were doing heterotrophic plate count or coliform testing. flush or no flush. So when you're doing coliform testing, you flush the outlet. Well, you don't want to do that when you're collecting samples for Legionella. And the reason is you're asking a different question. You're asking a question, when I step up to this fixture, am I going to be exposed to Legionella? So when you collect an immediate sample after opening the fixture, and you don't flush because flushing reduces recovery. And it went, in our case, it went from almost 98% of samples being positive to down to less than 70%. So don't flush the outlet before you collect the sample for Legionella. I wanted to say a little bit about swabs, and they are used to sample the biofilm. And when you do a case investigation, you want to collect both a swab and water. It improves the likelihood of detection. If you're doing that, collect the swab first, then the water, and you're doing this from the hot water system. There's often questions about the time it takes from the sample collection to delivery, and there's a couple of sources of information that show that there's no significant increase or decrease in Legionella viability when the sample is delivered to the laboratory within 48 hours of collection. So we did a presentation at the American Association of Professionals of Infection Control, and then there's a publication in Water Research, which I'll show here, effects of holding time and measurement error on Legionella culturing, and you can get this online in Water Research, and this was published last year as well. So no significant effect of transport. Well, what happens in the laboratory? So I want to talk a little bit about laboratory testing. You can find Legionella by various methods. You can look at it directly by direct visualization, culturing, or molecular methods. Well, here you go. I always like to introduce my audience to Legionella up close and personal. And these are pictures of colonies of Legionella with classic morphology, ground glass appearance, iridescence. So Legionella, my audience, Legionella. So that's what Legionella looks like by culture. Now, culture remains the gold standard for detection of Legionella, and it's more reliable than some of these rapid techniques like direct fluorescent antibody, immunochromatographic tests, polymerase chain reaction, and dip slides. It is laboratory-based culture is the industry standard. Part of the reason for the emphasis on culture is that when you do epidemiologic investigations, you want to have the organism from the patient to compare to the organism you've isolated from the environment. This slide just shows you a pulse field gel electrophoresis gel, and we're looking to see if there's identity or the organism from the patient is identical in its banding pattern to the organism from the environment. So that's why having the organism in hand by culture is so important. There's a lot of interest in molecular methods, but I wanted you to be aware that the CDC does not recommend genetic probes or PCR for the detection of Legionella either clinically or in the environment. And the reason is that they want more data regarding sensitivity and specificity. So I wanted to take a moment to talk about that. And PCR, or molecular assays, and false positivity. What that means is that PCR has been shown to be positive when culture is negative. And this is particularly true with the genus probe, not the one for Legionella pneumophila using the MIP sequence. And it's explained away by terms like false positivity, the presence of viable, non-culturable Legionella, meaning Legionella can't grow in culture but it's there, or dead Legionella living or not within amoeba. So these are the explanations for why PCR has been positive but culture negative. Well, it turns out that there might be another explanation, one that shows that organisms, other organisms, not Legionella, have cross-reactivity. So I want to sort of tell you a little bit about some new findings that we have made that explain why PCR is positive when culture is negative. Those false positives are probably due to a high level of sequence similarity in the 16S ribosomal RNA between Legionella and other organisms. And so on the slide you see organisms that were detected by cross-reactivity by two methods. Polymerase chain reaction, organisms like Aeromonas, Pseudomonas, Stenotrophomonas, and E. coli. Cross-reactivity with this 16S probe. And with another method called LAMP, non-tuberculous mycobacteria. So these organisms are very common in water, and if you've got cross-reactivity, which we demonstrated, that explains why these genus probes are cross-reacting. So I would not recommend PCR genus probes be used as a tool for you to look for Legionella in your water distribution systems, because you're going to get a lot of positivity that can't be explained. Well, if you find some Legionella, is the sky falling? That's our Chicken Little there. And I want to talk a little bit about what's acceptable. And like, is there a magic number? You know, where do we land on associating how much Legionella there is in risk? Well, I like the concept of establishing targets, action levels, minimum levels and goals, and you know, asking the question, is zero really necessary? Now, we don't live in a black and white world, so you're going to find some Legionella, and what happens if you chase zero? So EPA, you know, sets these MCLs and MCLGs typically for contaminants of various types. So I want to use that as an example. So does the EPA set zero for poisons in our water like arsenic and cyanide? So the maximum contaminant level you can see on the slide is not zero. We certainly can have a goal of zero, but you know, it's okay to have a little poison in your water. Well, what about the Food and Drug Administration? Now, you're going to think about me next time you have some canned corn. So does the FDA say that we can have no insect larvae in our corn? No, we can have a couple, 2 or 3 in our corn, and it's okay. So they don't establish levels of zero either. So when it comes to Legionella, I say zero is a goal, but it's not necessary to avoid outbreaks, and we've got tons of data to show that. And if you look for zero, if you chase zero, you're going to be very frustrated. So zero Legionella, in my experience, is nearly impossible to achieve in building water systems. Very, very difficult, even when secondary disinfection is applied. There's many species of Legionella can be present at any given time. And here's an important point, because people talk about Legionella as if it's one giant family of equal pathogenicity. All species don't pose the same level of disease risk, and that's why I use this sign, danger, Legionella ahead. All Legionella are not dangerous. Well, what does that mean? Well, Legionella is a big family now. There's over 58 named species right now, but they're not all equal when it comes to causing disease. Only about half have been implicated in human disease, which I think probably should surprise you. Only half. And some of the commonly found species in the environment rarely cause illness. And when they do cause illness, it's almost exclusively in those high-risk immunocompromised people. Now, what are some of those members of the family? Well, they have these unique characteristics of fluorescing under UV light. Some of them fluoresce red, like Legionella rubolucens shown on the slide. Some of them fluoresce blue-white, like Legionella nissa, gormani, dumafi, bosemani. We see these organisms a lot in water systems, but again, they don't cause illness. If you're interested in looking into this in more detail, on our website there's a table of Legionella species, and if you click on each row, you can actually go to the PubMed link for that article. So I encourage you to go there if you have some interest in looking at the original articles on these species and whether or not they're associated with disease. So you want to keep this in perspective when you're assessing risk. Legionella pneumophila serogroup 1 is the primary disease-causing species. Over 90% of the cases are Legionella pneumophila, and of those, 80% caused by serogroup 1. And again, these other species cause illness on very rare occasions. So for example, if you find in a building Legionella nissa, do you set the alarm bells going and say, okay, we're gonna shock chlorinate the system, we're gonna, in one nursing home, they stop showers, they stop drinking water. You know, it was terrible imposition on the staff and the patients, so let alone costly. So there's very little evidence to support such draconian actions when there's no disease associated and a non-pneumophilus species is isolated. So I just want to sort of wrap up by talking about the future of monitoring. built environment. So you might have heard about the microbiome of your body. They're looking at these organisms in our gut and on our skin. Another favorite new word in microbiology, microbiome. Well, they're doing the same thing in the built environment. And I ran across this paper. It's a 2009 paper from the Norm Pace group in Colorado, where they took this technique, phylogenetic methods and sequencing techniques, and they looked at the microorganisms in that consortium in a shower head. Well, we took the same technique with the same group of investigators, this 454 pyro sequencing, and we looked at our building that had the monochloramine system. And we just asked a simple question: how was the treatment with monochloramine going to change the composition of the organisms within that water system? So this slide very simply shows you by color the shift. So the top 3 bars are the control building with no monochloramine, and the various colors represent the bacterial taxa. And the bottom 3 bars are the monochloramine treated building, and this is May, June, and July, each of those 3 bars. So you can tell by the color that the distribution and relative abundance of organisms was dramatically different and shifted after monochloramine treatment. So it's a very cool tool, which I think has some future in evaluating the microbial communities in our water systems. And this article is published now online in Systematic and Applied Microbiology. So, you know, we got to know our history, as my mother used to say. So what did our friend Ben Franklin have to say about drinking water? With wine comes wisdom, with beer comes freedom, and he said, with water comes bacteria. So we changed it just a little bit. With water comes Legionella. And we came up with our own novel prevention approach, Legionella lager. We actually made Legionella lager. So we'll have a little fun with the concept of prevention. Maybe we should just be all drinking Legionella lager and we'll be fine. So I'm going to conclude my comments now, and I thank you so very much for spending this time with me, and I think we'll open it up for questions now.
Okay, thank you, Janet. That was very interesting and enlightening, hopefully, for everybody, I think. And we do have a couple of questions already, and I'd encourage everybody who has questions to type them in, and we'll try to answer those. We've got some time here before our scheduled wrap-up, and we certainly can address quite a number of questions, hopefully. First question, what are the symptoms of Legionnaire's disease?
Well, that's a great question. What I alluded to early on when Dr. Yu did his first studies at the Pittsburgh VA, and one of the findings of that study was that the symptoms and clinical indications of Legionnaire's disease are really no different than other forms of bacterial pneumonia. Typically, a person with Legionnaire's disease, first of all, it's pneumonia, so it's not, you know, I've got a cough or bronchitis. It's pneumonia, so it's chest X-ray confirmed pneumonia. Typically, very high fever, 102, 104. About 20% of the cases will have diarrhea, and of course shortness of breath. Now, other criteria that have been associated clinically are looking at hyponatremia, low sodium as a clinical indicator. But when the studies were done to comparing different types of pneumonia, there was nothing that fell out that identified this pneumonia as Legionnaire's disease. So that's what makes it a little challenging for clinicians when they see someone with pneumonia. If they aren't thinking about Legionella and they don't use an effective antibiotic, that individual can worsen very, very quickly and go from, say, unilateral pneumonia on one side to bilateral pneumonia and require intubation and respiratory support. So it's high fever, shortness of breath, cough, some diarrhea.
Okay, another question that we've had concerns the presence of Legionella in source water, especially groundwater, surface water. Is there any data available about how commonly it's found in source waters?
Yes. And actually, some of that data came from investigators at the EPA. So they went out and looked at various source waters, river, groundwater. So you've got surface water and groundwater, and you're going to find Legionella detected in all of those. So there isn't a source water that has not been found to have some evidence of Legionella. There is some chatter, so to speak, that surface water sources may be more prone to having conditions more conducive to Legionella. And one of our early studies of multiple hospitals in western Pennsylvania, actually one of the findings that fell out was that the hospitals on one particular river in this area were more likely to have Legionella than hospitals located on other rivers. So I think that as time goes on, more work's going to be done on source waters, and we might find, and maybe it's that weather impact, where you've got the opportunity with either wet weather events or drought to impact the quality of that source water when it's a surface water, more so than when it's groundwater. But basically, Legionella has been detected in all types of source water.
Okay, thank you. A long question here. I'll see if I can let's see if I can get it right. Do you consider finding non-Legionella pneumophila in the environment as an indicator that the water system is conducive to growth of, I think, serogroup 1 or other pathogenic species?
I'm familiar with this question, and I'm really glad you asked it. There's some talk, and it's mostly based on one study, and it's a French study. So the hypothesis or the assertion is, if I find, and we'll just use Legionella anissa as the example, if I find this non-Pneumophila species in my water system, the assertion is that it's somehow related or a predictor of the presence of our bad actor, Legionella pneumophila serogroup 1. And that has not been consistent with my experience, and I believe that relying on one study to make such a broad assertion is not well founded. So when I say it's not consistent with my experience, so we did a 20 hospital study across the United States, and we did both clinical surveillance for Legionnaire's disease and we did environmental surveillance quarterly for 2 years. And one of the hospitals only had Legionella anissa, and only had Legionella anissa every time we tested. So here's a specific example that counters that French study, where the presence of a non-Pneumophila species did not predict the eventual occurrence of Legionella pneumophila serogroup 1. So I do not believe that the presence of these other species is an indicator and somehow predictor of more serious risk condition. Certainly, we recommend that you don't sample a building once. And that recommendation to sample multiple times is in that paper, which was published in Infection Control and Hospital Epidemiology in 2009, I think. And if you're interested, the person asking the question is interested, I can send you that paper. So we recommended that at least for the first year, in the case of a hospital, that quarterly sampling be done, and we recommend 10 outlets in the building, plus the hot water return or hot water tanks. So it's not a huge number. But if you do it on multiple occasions and you establish your baseline, which could be no Legionella present at all, it could be some Legionella but not Legionella pneumophila, or it could be, for example, Legionella pneumophila serogroup 5. There was another hospital in that study that only had Legionella pneumophila serogroup 5, and we did active clinical surveillance and found no evidence of illness. So again, the reason that I spent a little time talking about this differential pathogenicity, all Legionella are not created equal with regard to their ability to cause infection in humans. And to assert that they are is going to lead you down a path of dramatic reaction, which would be unnecessary, costly, and a tremendous imposition on the building occupants. So let's deal with what we know. We know that the vast majority, 80–90% of cases of Legionnaire's disease reported in the United States, whether diagnosed by culture or urinary antigen, are due to Legionella pneumophilus serogroup 1. There's actually evidence, basic science evidence, that shows that it's more pathogenic, both for human cells as well as other cells. So that's what we know. So we know that there's some hierarchy in the ability of these organisms to cause illness. So to treat them all the same is scientifically unfounded and unwise from a public health point of view.
Okay, thanks. So we'll move on to another question here. This one didn't totally come through, but I think I got enough of it. This question was about ozone, and it's obviously something that's used on the Safe Drinking Water Act treatment side. What about for Legionella?
Mm-hmm. So ozone is a great chemistry, highly reactive, highly effective, if you can maintain a residual. So that I make the emphasis if, because it's so highly reactive. When you would put it into a building water system or in a cooling tower, for example, with a desire to control Legionella, it can't maintain the appropriate level long enough and far enough in the distribution network to be effective. So way back in the early days of Legionella disinfection, in the 80s, this was tried in the hospital, and they just could not maintain an adequate residual. In cooling towers, there's some companies that try to use it with multiple application points in the cooling tower basin. So by doing that in a confined water basin, you have more chance to control Legionella, but because of its high reactivity, it's really not appropriate for building water systems.
All right, a similar question about the effectiveness of UV.
Well, because we've been, over these 30 years, trying everything, we also evaluated ultraviolet light in building water systems. And this is what we found. So if you put the UV light on the water coming into the floor, for example, in a hospital wing, and you turn it on, you are going to have no effect downstream. So you might be disinfecting the water coming through the unit, but all the fixtures, all the faucets and showers and pipe downstream, Legionella is living happily ever after. So what we did was we put the UV unit on, and then we did a shock chlorine disinfection. So we disinfected the downstream piping and ran the UV unit. Well, what we found was that the UV unit scaled up. The quartz sleeve that the lamps are in would scale up because, our drinking water has scale forming capability. So then we put a pre-filter on it. So there's a pre-filter before the UV unit, and then disinfected downstream. And we found that the outlets would stay negative for Legionella for about 3 months. And then Legionella would come back, basically because of the rebound after chlorination. So the UV unit certainly can improve water quality, microbiologically speaking, as that water goes through it. But in a building water system, it's that downstream colonization, Legionella in every nook and cranny in the pipes and fixtures that you can't really address unless you maintain a disinfectant residual in the water at all times. So if you don't do that, then you're going to go up and down. So there's certainly a role for UV units. So for example, there's a publication in the medical literature where on a bone marrow transplant unit, they basically used an approach of redundant disinfection technology. They used UV unit. You could also call it, sort of throwing everything but the kitchen sink at it. So they used UV unit on the water. They used chlorine injection. They used copper silver on the hot. And they got good control on that bone marrow transplant unit water supply. So it certainly has a role, but I would not use it as a sole disinfection measure.
Okay, another question that asks about describing the life history, the stages of Legionella, I think the life cycle.
Well, I'd say it's complicated. So Legionella comes in the source water, and it makes it through the water treatment plant. And I actually have a slide that I use for some lectures that show, within the water treatment plant, because most of them continue to use chlorine. Chlorine is effective against lots of the other organisms that we have concern about, but Legionella is relatively tolerant to the levels of chlorine that we're using at the water treatment plant. So it makes its way past the water treatment plant down through the distribution network in very, very low numbers. So cooler water, and certainly in the Northeast, even during the summer, that water remains relatively cool. And Legionella is not growing there. It's there, but it's not growing. And then when it gets into the warm water system, where it finds its friends, it finds other bacteria that help it grow. It finds the intracellular niche with the protozoa, Hartmanella, and others. And it can multiply inside those protozoa, and it can also multiply in the biofilm in association with other microorganisms. And so it has this ability from its natural sources, where it's in so low numbers we almost can't detect it, to becoming amplified to a level of public health concern when it finds those other organisms and can multiply either intracellularly or extracellularly. So places that that you can have that amplification are, spas, hot tubs, cooling towers, warm water distribution systems of our buildings, decorative fountains that have submerged lighting that generate heat. So you're looking for the combination of temperature and nutrients and other microbes that help Legionella to multiply.
Okay, thank you. We had a question about any precautions that need to be taken when analyzing samples that are positive for Legionella.
Legionella is considered a class 2 microorganisms in terms of precautions, and so you can work with Legionella on the bench. You don't have to have those water samples under a hood. The recommendation is, if you were doing some kind of experimentation where you would have aerosolization of very large numbers, then you might want to use some protection by working under a hood. But it's perfectly safe to handle this water open on the bench without concern. There's basically been no laboratory associated cases of Legionnaire's disease from handling water samples from contaminated sources.
Okay, thank you. Another question, looking at recycled or reclaimed water and Legionella. Is there any research about how that's effective?
I have to tell you that when I was sitting in my first lecture where they were talking about water reuse, reclaimed water, I got a little alarmed as the Legionellologist in the room. Because there's no requirement for doing any evaluation or testing of these waters for the presence of Legionella, much like is true in other waters. But the potential for Legionella growth and dissemination, I think, is higher because of the way that this water is reclaimed and reused. And so, the regulations are there to look for coliforms and E. coli, and if you're spraying our vegetables with this water, there's different criteria, but you will not find in any of these descriptions a concern raised about Legionella or a requirement to test for Legionella. So I think it's an area where there's certainly more research being done, and I believe American Water was just a recipient of a grant to look at this. So there's a tremendous interest in it, and I think a tremendous need for caution in handling this water because I think that there's actually, I know of 2 publications in the literature where rainwater harvesting was done, and this was in Australia where water scarcity is a big problem, and cases of Legionnaire's disease were a result of exposure to this rainwater harvesting. So again, the combination of the factors of warmer temperatures and higher nutrients makes it a nice environment for Legionella, and we need to be careful about that. And I think some of these people that are using rainwater harvesting, they'll store this water in large storage tanks, some of which are below ground in areas where that water can heat up substantially. And then sometimes there's no requirement for treating that water before it goes into the building to be used for various reasons. And so certainly there's potential there for a public health concern.
Okay, have another question here. The questions are rolling in, so everybody has been stimulated to ask a lot of questions by the presentation, and that's what we'd like to see. This relates to the comparison of clinical cases and the presence of Legionella in the hospital in the water, and what factors do you look at to make the connection, or maybe not make the connection between the amount of Legionella that you find in the hospital water and the actual clinical cases?
Okay, well that's sort of like the gazillion-dollar question, and we and others have asked that over the years. So early on, when we were doing the testing in the hospital in Pittsburgh here, we would collect samples from the water distribution system every month, and we did this for years. And at the same time, Dr. Yu and his infectious disease colleagues were looking at every case of pneumonia and using Legionella diagnostic testing on them. So you have to do, in order to evaluate this question, you have to do both environmental surveillance and clinical surveillance so that you're measuring the up or down of Legionella in the environment and the up or down of Legionella in the patients. So when this was done systematically, both by ourselves and CDC investigators, there's a publication by Jacob Kuhl, when this was done, there was no correlation with the concentration of Legionella, the CFUs, colony-forming units of Legionella, recovered in the water or at the site, and occurrence of disease. There was an association, increased chance of disease occurrence, as the proportion of the sites positive within the building went up. So in our case, when we tested month after month after month after month, when the percent positivity went above 30%, they would find a case. And then we would disinfect. And at that time, we were using heat and flush. And it would drop the percent positivity down dramatically, close to 0. Then we would sample every month, and it would start to creep back up. Remember that rebound effect. When it would creep back up over 30%, boom, there'd be another case. We'd disinfect, wait, test every month, above 30% a case. So we showed that repeating pattern over time. And that's where this guideline that we published on, and that was in the Allegheny County Health Department, of colonization within the building, percent positivity, that's where it came from, parallel environmental and clinical surveillance. And Jacob Kuhl from the CDC came to the same conclusion. There was no correlation on the number colony-forming units, but there was in terms of the proportion of outlets positive. And this is the way you should think of it. When you take a sample from a fixture, whether it's a shower or a faucet, there's going to be variability in the numbers of colonies recovered. It depends on how often that fixture is used. Was it used 5 minutes ago? Was it used 2 days ago? So there's high variability in colony-forming units. But it's going to be consistently positive, so that positive or negative has worked out very well. So that's why the concentration has not been predictive of disease occurrence. But the probability of a patient or an individual running into Legionella, that proportion of sites positive, if that probability is high, a high proportion of those sites are positive, then the risk of getting exposure, and then if you're the right person going on to develop disease, goes up. So that's why there's no magic number, no colony-forming unit that's predictive of disease. But we and others have found that the proportion of sites positive within the hospital has been predictive of disease occurrence.
Another question about the filters that you mentioned that are successful in removing Legionella. And are there other filters like reverse osmosis that would also be effective?
Certainly reverse osmosis would be effective, but it's not been applied, for example, like I mentioned, on a unit, a bone marrow transplant unit or something like that. I'm not aware of that technology being applied to provide a certain quality of water. These point-of-use filters, what's nice about them is they're applied with like a quick disconnect fixture, so you pop them on and pop them off, and that can be done rather quickly in an outbreak situation. Given their efficacy, it's a good sort of first line of defense when you're encountering an emergency or an outbreak, and certainly as initially there was one manufacturer. Over the years now there are multiple manufacturers, and I just encourage people to be careful about sort of making sure that these other manufacturers have gone through rigorous trials to make sure that they're efficacious. So for example, one manufacturer had a recall because of an outbreak. I think it was in a neonatal unit of Pseudomonas where the filter did not perform, and there was actually disease associated as a result. So all filter manufacturers and their products are not created equal, so you want to make sure that you do your due diligence in selecting them.
Okay, here's a question about transmission through drinking water directly. Legionnaire's disease can only be caught if you choke or aspirate while drinking contaminated water, correct? In other words, merely drinking water does not transmit the disease.
Well, when I mentioned aspiration, and I talked about microaspiration, because there have been studies that actually look at how the secretions in the upper airway and how many of them actually make it down into the lung. And based on those studies and direct clinical observations, you can have either overt aspiration, like the questioner describes as that choking, or microaspiration. So the sequence of events goes like this. Legionella is in the water that you ingest. It's in contact with the upper airway, so your pharynx. And then there are tissue macrophages, and the ability of those secretions to get down into the lung helps Legionella then get a ride down into the lung. And so it's coming in the drinking water, it's coming out the fixture, you drink the water, and then the organisms that are in that water transiently colonize the upper airway and then make their way down into the lung. And certainly that's been a major mode of transmission in hospitalized patients. And if you talk to medical people, they're very familiar with the syndrome of aspiration pneumonia. And most of the time they're thinking about other forms of respiratory pathogens, but the same is true for Legionella. It can cause pneumonia through this mode of transmission, just like those other organisms. So it is in the drinking water. On your side, because it's cold water, and you have that treatment technique rule, there's not much more that you can do on that side other than that recent publication sort of highlighting some of the things that can be done in maintenance of these distribution networks and water storage to minimize growth of Legionella in that source water.
Second part of the question from the same questioner, are there any data showing the prevalence of Legionella in bottled water versus tap water?
That's a great question too, because some of these transplant units just decided not to use tap water and use bottled water. In my own experience, having tested bottled water, I haven't found any Legionella in the bottled water. In some of the reports that are in the literature, there's been some genetic PCR evidence of Legionella in that water, but now you know why you should be skeptical about that. But certainly they've seen Pseudomonas grown by culture from some of these bottled water sources, and so one of the cautions for hospitalized patients is to be careful if they're immunocompromised, perhaps not to use bottled water because it could be a source of Pseudomonas aeruginosa. So our recommendation for really high-risk patients is to use boiled water, and even if they're at home, to use boiled water for drinking.
Okay, we have a question that relates to the Veterans VHA Directive 1061 that the Veterans Health Administration just did late last year. Recommends a thorough evaluation of building plumbing and subsequent fixes, fixing dead ends, correcting temperature issues, periodic flushing, and prescribes disinfection as a last resort. Would you like to comment on any experience you have with the corrective actions taken on building plumbing and how that how effective that is, how that works with subsequent disinfection?
I'm grateful for the question because there's some things in the new version of the VA directive that I agree with and some things that I don't. So back in 2008, the first VA directive, and I applaud the VA for being proactive. And so what that means is that they are testing their hospital water systems for Legionella and responding to the presence of Legionella in a proactive manner, not waiting until disease occurs, which is consistent with the approach that we have always recommended. Now, some of the things that so those are some of the things that I like about it. What I have a little trouble with are some of the things, so when they're sampling for Legionella, in the new directive, they're telling them to sample 10 hot and 10 cold samples. Well, you're going to find a little Legionella in cold water, but the most significant source with regard to disease transmission is the hot water. So what happens by sampling the cold water is you trigger a bunch of events that really are not going to mitigate disease transmission. So in the future iterations, I hope they eliminate that testing of the cold water. The other thing on the cold water side that I took some objection to was there's a number in there of 68 degrees. And if your cold water is above 68 degrees, it recommends disinfection. One VA is actually putting a chiller plant on their cold water to achieve these temperatures. And there's nothing in the literature that makes a link to the presence of Legionella in cold water as a significant disease threat. All of the body of knowledge really has focused on the parts of the water distribution system that are conducive to amplification of Legionella, which is higher temperatures and the presence of other organisms helping Legionella out. Now, some of the corrective actions, things like disinfecting locally. The way I refer to this, not just with regard to the VHA directive, but putting the faucet in a bucket of bleach and then putting it back on and kind of believing that that's going to control your problem. Well, that's not going to control your problem, because if you're colonized upstream of that fixture, it's going to be recolonized in short order. So it's a bit of busy work for the people that are already busy within the facility. And so I think while you could do that as a stopgap measure, it really takes a lot of time and effort on the part of the plumbers that already are short-handed. So actions like that really are not very effective and have been shown to not be effective in published literature. So The other approach that they have, which is related to that earlier discussion about non-Nemophilus species, is if they find non-Nemophilus species in a surveillance culture in the water distribution system, it recommends that they go back and test it again. And the idea is if you've got no Legionella pneumophila on 2 rounds of testing, then you're okay in the sense that there's no serious disease threat. And they give you the option then. Doesn't require you to do disinfection. You can if you think, for example, if it's a high-risk unit, you might want to do it. But I like the fact that it's sort of staged that way and recognizes that other species are less pathogenic. And it also emphasizes culture as the method of detection for Legionella. And again, that's the industry standard, the gold standard, and remains so to this day. So unless maybe you have a specific question about some of the remediation, I'd be happy to answer those too.
Okay, Janet. I think Daryl's going to have to drop off, so I will pick up the rest of the questions here. We've got about a little more than a half a dozen. If you've got the time to answer those.
I'd love to.
Great. And for the folks on the line, we're about at the end of our scheduled time. If you guys need to drop off, we are recording the webinar, and we will provide a Q&A document after the webinar with answers to any questions that we don't cover. So the next question that's up is, what do you think about the need to monitor for lead and copper or THMs at healthcare facilities providing secondary disinfection?
Oh, that's such a can of worms. I love that. Okay, so here's the thing, and you know, I'm pragmatic. So the hospital receives treated water, and that water is deemed safe because it's passed the criteria at the municipal treatment plant. And now you do supplemental disinfection. Well, when I advise people, I advise them to apply disinfection to the hot water only. And I do that because, number one, that's the primary source of the organism. And number two, I don't want to add more chemicals to the drinking water, the cold water, than we already have. So I don't approach that lightly. So if let's just say that the application of secondary disinfection is on the hot water. Well, we're not drinking huge amounts of hot water. So I would say no, you don't have to test for disinfection byproducts in the hot water. Now, the requirement for all of these hospitals that are using secondary disinfection to be required to monitor for everything that a water treatment plant has to monitor for, because the water treatment plant is sending drinking water to millions of people, makes no sense to me, because you know, we're applying secondary disinfection for a very limited purpose, and the water that's being received has already checked the box. It's free of coliforms. It doesn't have tremendous amounts of lead. So why are we asking the hospitals to repeat those tests on water that's already been shown to meet those criteria? Just because the regulators want to take the Safe Drinking Water Act in its entirety, approximately, and apply it over here on top of a hospital. And to me, it just is illogical. So what I would like to see is consideration of the fact that they're already receiving this water, and that some of these requirements, so for example, the requirement for an operator, you know, somebody who's licensed at the drinking water plant to run a drinking water plant, now they want to require a hospital to have a certified operator on site. You know, these are things where moderation and modification of the requirements need to be made, because it's not the same. And there are various criteria, I think, that can be adjusted within reason and maintain safety of the water supply. So I'm hopeful that sort of pragmatic people are, sort of having their meetings and realizing that another level of operator licensure, for example, needs to be created for somebody that's got a system on site and there's a drinking water professional, water treatment professional operating that system, that the same criteria for a large municipal water treatment plant is not applied at a hospital.
Great. Okay, the questions are pouring in. What is your current and best recommendation for disinfection for hospitals? Like any particular type of disinfection that you think might be more beneficial than others?
The way I answer that question is a little bit probably not very satisfactory, but it depends. So for example, in the hospital that I mentioned earlier, that was the place that we did the first study on chlorine dioxide. The reason that chlorine dioxide was applied there is because it was a large campus and it had a large reservoir that supplied the entire campus. And it made more sense to have centralized water treatment at that reservoir than having individual hot water applications of another sort, say copper silver ionization. It just was going to be too expensive to have all those individual systems and much more cost effective and more manageable to have it on the reservoir of that hospital. So some of the determination of what disinfection technology should be applied at a given location are the engineering parts. What kind of distribution is it? Is it multiple buildings? What is the water quality? So when we go in and do a risk assessment or an assessment for disinfection, we measure water quality. We do a hand over hand of the system to fully understand the hydrodynamics of the system. How many cold water entry points are there? Is the water balanced? How many hot water systems, just to name a few. In terms of what technology to apply, in the example that I gave you of the monochloramine and the copper silver, in a hospital that's experiencing an outbreak, it's a bit of an apples and oranges situation where if you're being proactive, you have the benefit of time to consider your options. You have some time to allow disinfectant to work. And in a situation like that, a slower acting disinfectant like chlorine dioxide might be appropriate. But in a situation where there's been cases and there's a lot of public health scrutiny, you need something that acts quickly. And in my experience in all the evaluations we've done, monochloramine application has worked the fastest and has been very, very consistent and easy to maintain. So those are some of the considerations in selecting a disinfection technology.
Great. Thanks, Janet. How long does it take for a new hospital to have a positive Legionella sample?
I asked the same question back in the 80s and early 90s. So we were at one VA hospital, and across town they were building a new one. And so I said to myself the same thing. I said, okay, if I'm there culturing the water system when they put the first faucet in and beyond, what am I going to find? And the reason I asked that question, and maybe the questioner as well, is there was sort of this idea that the building had to be old and that new buildings wouldn't have Legionella in them. Well, you can imagine what I found. So I was there, water bottle and swab in hand, when they put the first fixture on. So I tested that first fixture and the ones after that and the ones after that. And even before the hot water system was turned on, I found Legionella. So that was within months of the first fixtures being applied. Now this sort of segues over to the concept of commissioning. So in building construction like this example I'm giving you, they pressurize the water system, the cold water and the hot water, and oftentimes that water lays in there a long time, months, before the building's actually occupied. Now they've checked the box, the contractor, and done a commissioning chlorination. but that basically had no effect whatsoever on Legionella in the building because of the rebound effect, and maybe also because of the way they do the commissioning chlorination. And there's actually some examples in hospitals where new construction being occupied by patients resulted in an outbreak because they weren't thinking about or testing for Legionella prior to occupancy. And this is one of those blind spots that we try to improve awareness around construction activity and new buildings. So new buildings are just as at risk for Legionella colonization as old buildings, and commissioning will not rid Legionella from that building.
All right, thank you. Would maintaining a chlorine residual of, say, 0.2 micrograms per liter in the distribution system have any measurable positive effect?
Unfortunately, no. So I'm aware that the regulations require a measurable residual of chlorine to be in the water when it reaches the building. Even a 0.5 and even higher that we measure in buildings when we do these assessments have Legionella in them. So again, the idea that if you could maintain a chlorine residual to control Legionella, it would have to be much higher, 10 times higher. 2 to 4 parts per million is really necessary to keep Legionella under control, and certainly you don't want to do that for various reasons. So unfortunately, the amount of chlorine that you typically maintain will not have any appreciable effect on Legionella colonization.
Thanks, Janet. Which regulatory agency requires or monitors Legionella inside of the buildings? Typically, if a hospital receives water from a public water system, responsibility of the PWS stops at the water meter of the hospital. Also, if a hospital provides treatment of the water inside of the building to remove Legionella, who governs the operation of those treatment units?
So historically, nobody. So for a long, long time, regulatory agencies, Center for Disease Control, Departments of Environmental Protection, EPA, were certainly aware that outbreaks of Legionnaire's disease were occurring in buildings and hospitals, and that secondary disinfection was being applied. But there was no push to sort of dip your toe into the regulatory water to kind of go inside the building. So my understanding of the regulatory authority really meter. And because of recent developments in no small part the catastrophe at the Pittsburgh VA, EPA, CDC, and Departments of Environmental Protection made a decision, I believe, that they were going to wade into those waters. So what happens after a secondary disinfection system is installed in, say, a hospital is really regulated by the manufacturer's recommendations on how to operate that equipment, what to monitor and measure, and also maybe other people within the facility or people they consult with making recommendations for safe operation. But it hasn't been regulated. We're at that tipping point where that's going to change, and so that authority or that responsibility really did end at the meter. And I just want to point out that disaster has not struck in terms of water being unsafe in the vast majority of these applications. So the regulatory change of a need to get in there and regulate is not because terrible things have happened in terms of the application of these disinfection technologies. I do think, this is editorial here, I do think that some oversight is a good idea. But I caution about overreach or having, too much regulation that is redundant or unnecessary and costly. So again, my plea is that that some moderation informs this decision on how to regulate. And certainly some of these technologies that are not covered under the Safe Drinking Water Act have been shown to be very effective and safe, and we shouldn't throw them out just because they're not covered under the Safe Drinking Water Act because they weren't used to treat millions of gallons at municipal water treatment plants. So I think that needs to be considered as well.
Great. Thank you, Janet. We'll just take a few more questions here, and then we'll let everybody go. And any unanswered pieces that we have, we'll forward those to you, and we'll send those back out to the audience. The next question we have, can Legionella live or grow within ice machines or colder temperature water systems? Is this even a concern?
It is a concern, and I have this great picture of a luxuriant biofilm from a narrow lumen flexible piece of pipe from a hospital ice machine. So way back in the 80s, we actually published on this. And it was interesting to me because then I learned about the inner workings of an ice machine. So that cold water pipe, narrow lumen, goes into the machine and sort of sits nearby or on top of the condenser compressor, which generates what? Heat. So it's a cold water source, but it actually warms up considerably because of that proximity to the inner workings of the machine. So it's not just Legionella that you'll find in that water or in the ice. It's also a number of other organisms that their growth is promoted by those conditions. So traditionally, cold water applications, where you use cold water in a building, you might find a little bit of Legionella, but you're going to find a lot more if that cold water is warm, and warm is above 77 degrees. And that number comes from a systematic study done in the UK on conditions in pipe materials that promote Legionella growth. So they didn't see appreciable growth until the temperature got above 77, not 68. So yes, hospital ice machines, a cold water source can have Legionella for the reasons that I listed. Now, in my experience, that source as a source for disease transmission was most significant for people, for example, that were bedridden. They had no other sources of exposure to water other than ice chips because of their severe debilitation. And I have seen cases of Legionnaire's disease transmitted and acquired that way. But it's not the most common mode of transmission.
Great. Interesting. Any thoughts on what a proposed MCL might be?
So it's not going to be zero, okay?
All right.
If it's me, don't make it zero, because now you're going to have everybody applying disinfection technology, and we really don't need it. Now, we don't need it because the disease is relatively rare, and we don't need extra chemicals everywhere because the risk is not high everywhere. We talked earlier about why an MCL of a colony forming units is not a good measure. But if you were going to put my feet to the fire and you were going to say, okay, we have to have a number, it's not going to be 0 and it's not going to be 10, because you can have, for example, another pet peeve of mine is if you go to the OSHA technical chapter on Legionella, there's this table there that came from a laboratory that just made the numbers up. They made the numbers up based on some survey data. So, for example, they have some numbers about cooling towers, and they say above so many hundred, the risk of transmission of Legionnaire's disease is really great. Well, if you do your homework and you go back to the origins of where that table and those numbers come from, it's a survey of cooling towers, and they had Legionella in these cooling towers. And if you're going to make a correlation with disease, right, you need to have some outbreaks where you're measuring Legionella in the cooling towers that caused the outbreak, right? So I looked at how many cooling towers they tested. Well, it was in the hundreds, so check, that's a pretty good size sample size. Well, then I asked the question, how many of those towers were associated with disease? 2. 2. Well, a sample size of 2, I'm sorry, your statistician is going to laugh at you. So there's no correlation in those numbers with actual disease causation. It's purely made up. So when you look at the drinking water part of that table, it has like 10 colony-forming units as a cause for concern. Well, that happens all the time, and there's no disease associated with it. So I really think the paradigm of a number of colony-forming units and establishing a contaminant level is going to be really difficult within buildings. Now, certainly in the water, if you were going to say the water distribution system has to have 0 Legionella in the cold water, well, that's an achievable goal. But that's not going to do anything inside the building. So I think in terms of the regulation right now, your treatment technique we know is flawed as an assumption for Legionella. Don't use PCR for the genus-specific probes to be your new measuring stick, because you're going to get positives all over the place. Use culture. And if you have no Legionella in 100 ml of water in your distribution network, certainly that's a checkbox that you can meet. But making clear that that's not going to have anything to do with what's happening inside the building.
Excellent. We'll just do 2 more quick questions here, maybe quick. Regarding the 30% positivity in outlet sampling, if the 30% positive were non-pneumophilia species, is this still predictive of disease?
No. So it's not predictive of disease because these non-pneumophilus species, now with the exception of Legionella mcdadii, now Legionella mcdadii has been known to cause outbreaks. So if I was going to say, is there a pneumophilus species I would be concerned about, it being mcdadii. But for the other ones, like the blue-white fluorescing species, the red fluorescing species, they are not an indicator of disease risk. And for example, we've published our recommendation, even if you had a high level of colonization with these other species like Legionella and Nissa, there's no evidence for disease causation. And I gave you a couple examples, real-life examples of prospective studies that we did that support that. So it's not like I'm making it up. It's based on very carefully collected prospective data where environmental testing was done concurrently with clinical surveillance, and there was no evidence of disease causation. So what I say about using the measuring stick of percent positivity and 30% is that it's one indicator, and that mostly it's Legionella pneumophila, and I get more concerned if it's Legionella pneumophila serogroup 1.
Okay. Another question. What regulatory code language have you seen that is applicable to public health requiring secondary water treatment systems?
We haven't really seen any regulatory language about that. So I mentioned to you in the 90s here in Allegheny County, the Allegheny County Health Department with Dr. Yu and colleagues developed the first guideline for hospitals. Now, there's other guidance out there like CDC, like OSHA. As we speak today, there is no standard having to do with evaluating the risk of Legionella in building water systems. That may change soon. So many of you are probably aware of the American Society of Heating, Refrigerating, and Air Conditioning Engineers, ASHRAE's proposed guideline 188, and it's 188 P because it's still proposed. And the guidance document is in its 5th public review, which will end, it's a 40-day public review which will end in April. So I encourage you to go to the ASHRAE Standards website and have a look at that public review document. So let's just say that this year it goes from proposed to approved. That will be the first time in the United States history that there is any standard that has you shall, you must language in it for how to approach assessing the risk of Legionella in building water systems, both potable and utility. So that's not exactly regulatory, but I'm told that once that's approved, it will be short order before it's incorporated into building code, which then has legal authority. So we're not too far away, I think, from having some standard language that's got some teeth.
Great. Let's sneak one more quick question in. As a microbiologist, why focus on Legionella? If a hospital is going to install treatment only when they find Legionella, why shouldn't they install disinfection permanently, as there are a number of other pathogenic organisms that, if present in the drinking water, could hurt high-risk populations? For example, E. coli.
Right. So in hospital water distribution systems, the questioner is correct. There are other waterborne pathogens which we look for, things like Pseudomonas aeruginosa, Stenotrophomonas multifilia, Acinetobacter, non-tuberculous mycobacteria. All of these are waterborne, basically are amplified in a similar manner to Legionella, and secondary water treatment typically applied because of Legionella does have the added benefit of reducing these other organisms as well. And one of the things that we found that was really interesting on our monochloramine study is, as you know, when monochloramine has been applied in municipal cold water, some of the problems that were encountered were actually increases in other microbial populations, like total bacterial counts went up, non-tuberculous mycobacteria counts went up, nitrifiers and such. Well, when we looked for all of those in the water system where we applied it to the hot water, we didn't see any of those negative effects. The total bacteria count went down, we didn't find nitrifiers, and we continue to evaluate this. The amount of non-tuberculous mycobacteria went down too, albeit slower than Legionella and these other organisms. So, you know, the point is well taken that there are other benefits to hospitalized patients from secondary disinfection. But again, I think the focus really should be on applying these disinfection technologies to the hot water, not adding more chemicals to the cold water.
Great. Thank you, Janet. That's the last of our questions. I wanted to take a moment just to thank you very much for an incredibly informative webinar and presentation. Thank you for sticking around and answering some extra questions. Thank you to the audience for all of your fantastic questions. We're going to pull some summary materials together and hopefully have those distributed to everybody on the webinar sometime early next week. That will include a video capture of this webinar and Dr. Stout's slide deck. We'll get that Q&A document out as soon as we can as well. So thank you again, everyone who participated, and at this point we will close the webinar.